I think folks, lots of times they'll shy away from things that they don't understand. And so one of our roles is to help them to understand that, help them to be an advocate, because I think lots of times they don't know the right questions to ask or even to ask for help.
This time on Cancer Buzz, the current state of financial health literacy for patients with cancer. If you manage or administer a cancer program, big or small, or work with patients at any point during their treatment journey, this is a discussion you won't want to miss. What you need to know is next. Welcome to Cancer Buzz. I'm your host, Summer Johnson. Cancer care professionals know firsthand that the rise in healthcare costs for people with cancer has placed an even larger burden on an already physically and emotionally burdened patient population. Research shows that many Americans have low financial or cost-related health literacy. Financial health literacy is defined as the degree to which someone has the ability to understand the cost related to cancer care, medical treatments, medications, insurance costs, and other costs, and also understand available financial assistance resources, which allows the patient to make appropriate health decisions based on the cost. One study showed that close to 40% of respondents couldn't accurately define the term insurance premium. Without adequate financial health literacy, patients can feel as if they're left to choose between their cancer treatment or their family's financial well-being. And this makes access to financial advocacy services all the more important to make sure patients can follow their treatment plans. As treatment options increase and some cancers become chronic conditions, financial counseling services, which were once considered value-added services for programs, have become a necessity. ACCC's 2019 Trending Now in Cancer Care survey found that 43% of respondents wanted to expand financial advocacy services at their program, and about one-third said they plan to add financial advocacy staff this year. You heard earlier in the show from Sarah Hudson-DiSalle, an oncology pharmacy manager at the James Cancer Hospital at Ohio State University. Dr. Hudson-DiSalle has worked closely with patients for over 25 years as her program across the university medical system has evolved. She has seen the realities of increased patient financial burden and the growing number of underinsured patients. And she says staff all across the system have a role to play in helping patients understand and manage the financial realities of their treatments.
The program started in the James in 2001 with actually a pilot program. They had started with one patient and expanded to one became three became eight, and so on and so forth. But it actually started as a pilot to see if we could bring an ROI back for just one coordinator to see if they could help for patients who were even just leaving the hospital or the clinic. And in 2001, those were when some of the antibiotics that are generic now, it was, antibiotics, low molecular weight heparin, some of the antiemetics, growth factors that folks would need to go home because they were just sitting in beds, finishing courses of these therapies to start them. And really, one of the things we wanted to do was kind of start to break that cycle, help those folks get access to those medications and then kind of help them towards, a better outcome because they can do better at home. And then as we kind of grew and some of the insurance landscape has changed too, we actually help those folks to kind of navigate some of the systems of picking drug programs, especially with the onset of Medicare Part D. When that first was introduced and that initial enrollment period was much longer, we met with available beneficiaries and their families, help them to find the right information so they could make an informed choice on their prescription drug plans. And really that's kind of evolved into, Ohio State doesn't have a true navigator program. We've taken that role and kind of split it up just because of the sheer size of our organization. And so we do work closely with our financial counselors and our case management teams to do various pieces and parts of this to make sure either patients have access to these medications, we have authorization for medications, they're getting things that they need, but lots of times then we find, do they need help with housing? Do they need help with transportation? And we can make that appropriate referral either to our case management, social work, or financial counseling folks. And we've grown exponentially at Ohio State that we now service all of the service lines across the medical center. So it's not just in cancer that we help. And a lot of it, as you can imagine, we see so much in specialty medications, but then also in primary care medications, because you need to make sure that folks have access to care in order for them to stay out of your emergency rooms and stay out of your hospitals. And so it is kind of making sure that we have the right resources at the right time. So it becomes a lot of coordination. And the last couple of years, they actually split my position into two. And so I now just oversee the infusion piece of like authorization and access. And then I have a counterpart that works with our oral or through our retail services.
Do you think the issue of financial toxicity has gotten worse in recent years as we've seen more of that cost shifting to patients? Or do you think it's always been there and there's more of a focus from our community?
There's some data that's actually come out that we've seen really a gradual increase of financial toxicity since 2008 that across all payer types. And that includes even, your Medicaid, managed Medicaid folks, even, the small out-of-pocket expenses that states ask them to pay. Sometimes there's just not enough resources, because if you think about folks with comorbid disease, not just cancer, they're going to have 5-6 medications on an average. And if they have a copay on each one of those, they may or may not be able to pay that. But also then out of pocket for both commercial and federal folks, we've seen an increase of reported underinsured to grow by about 25%. I don't have the study right in front of me, but we're seeing that. It's not uncommon to see someone that has a $5,000 or $10,000 deductible before they're even going to have any type of benefits. And then if they're out of network, especially with some cancer programs, you may not be in network with all insurances. And depending on if you're near a contiguous state or if you have a specialist that folks come to see, you maybe have patients that are dealing with out-of-network benefits, and then they may not have an out-of-pocket max. And so you really need to make sure that you're finding those folks, trying to help them. But we have seen, I think, this start to grow, and payers are putting more onerous back on the patients. They are a portion of the solution to financial toxicity. I think everyone has a little bit of role to play, and payers absolutely have a role to play in those health plans.
From your experience, how often do patients neglect treatments because of the cost?
I think we see folks that they'll fall off the map per se, or they've been lost to follow-up. And many times we'll have patients that actually have deferred treatment until they can work out their coverage with folks. And we try to make that or find those resources for the patient that they don't have to interrupt therapy or that they don't have to delay therapy due to what their expenses will be. And that being said, if someone doesn't have insurance and they come here, we're a state institution, so we see everyone. So we have mechanisms in place to screen these folks for charity, for some programs as far as decreasing the amount. So, if they come in with a regimen that they need to start, say we have a patient that needs to start R-CHOP, and, we can get the rituximab, we can get the pegfilgrastim for that patient. Some of the other medications, then we're going to work with financial counseling to decrease that bill as much as possible, or to see, is it going to be any type of a charity care that happens. But I think that, cost is that number one deterrent for folks, that they will see that and say, oh, good golly, I'm not going to pay this amount, or do I have to get a loan on my house? This has been a conversation that we've had with folks. The conversation that we have with those patients is, let's see what we can do. We don't want you to do any drastic measures. Let's see what's available to you first. And so to maybe take a little bit of that burden off so they don't deter therapy. There's copious studies that are out there showing cost is your number one factor that folks are not adherent to, like oral oncolytics. And I think that it's going to be my plug for parity, at times of making that the same. Think about, you have your traditional Medicare that they have a supplement. Well, Part D doesn't have a supplement. So there's nothing to pick up that remaining out-of-pocket expense. And so with some of those specialty meds, they can have a $3,000 out-of-pocket initially. And that's a big deterrent for folks to say, well, is this worth it for me to start that medication? So we see it. We try to combat it wherever we can. I think folks, lots of times they'll shy away from things that they don't understand. And so one of our roles is to help them to understand that, help them to be an advocate, because I think lots of times they don't know the right questions to ask or even to ask for help.
You talked about some very decent data since 2018, talking about financial toxicity and as it relates to outcomes. Can you dive deeper into that and tell us what the most recent research tells us about the changes in financial toxicity and financial health literacy among patients?
So one of the things that we know from the data that cost of healthcare is increasing. We know that cost share for the patients are increasing. Everything across the board from drugs as we get to more complex therapies that we know can make a huge impact. But we are also seeing an economy that's not growing, and like folks' income is not growing at the same rate that their out-of-pocket requirements are at the same time. So then that way you have like a different curve that is occurring. If you can think about that curve that is growing, so each year you're going to have an exponential increase in your expenses to the patient. Your increase for, new and novel therapies that are coming out. But then, you may have folks that are on a fixed income. Really, if you look at your Medicare population, their income is usually very flat. That is not going to have that increase. Or you have someone, especially in a cancer population, they may actually have a decrease if they're employed in that primary employer. You may see that as a decrease of what that revenue is coming into the household. So those expenses are going to start to increase larger and larger, even if you have those two households. So if you have that more expenses that are going to be needed, and then costs are going to be increasing, but income isn't, you can see that increase across the way. And that has grown. And we have seen the payers kind of push back that expenses to the patient because they need to make their margin. They want to make as much money for their shareholders as they can. So since 2008, we have seen this curve kind of increase, and it's based on those factors. And it hasn't been really well reported until recently. It's probably 5 years ago. If you had said underinsured to many folks, they'd be like, what does that mean? I think it's much more prominent, and financial toxicity has become much more on the forefront of many folks' minds in the healthcare team, because they know that if it gets too expensive, we're going to see patients that will say, I can't do this, or I don't want to leave my family with lots of debt. So those are what we are seeing. And I think cost is always going to be that deterrent. You'll hear that folks are not going to eat because they're going to buy their medications. Food, shelter, and safety are your top three things that folks are going to do. And they will go without their medications before they will get rid of those top three. So those are things we want to try to help to alleviate that fourth need, or it could be the fifth, depending on what's going on in somebody's life.
Our next guest has overseen financial counseling for a number of years. She too has seen the market change in patient expense and the impact that has on patients with cancer. Lori Schneider is the operations manager at Green Bay Oncology in Green Bay, Wisconsin, where she oversees financial counseling services, insurance benefit specialists, medical records, and social workers. The goal of her program, to help patients know they have options and get them the treatment they need. But she says half the battle is getting the patients comfortable with opening up about their finances and what they do and don't understand.
I started our financial counseling program in 2005, started just helping patients navigate uninsured areas, so helping to find patient assistance medications from the pharmaceutical companies. And back then, we didn't have a lot of underinsured patients. We had more uninsured patients. In 2006, it became my full-time role. I moved into the clinic setting, worked closely with the physicians, the nurses, the pharmacy to figure out how can we do whatever we need to do on our end to help the patients get the medications and not be a cost burden to them, but also bottom line to help the business as well. Back then, our copays and deductibles for patients probably were at if we saw $1,000 deductible, that was probably really high back then. Now, if you fast forward that to current day, I mean, we're seeing deductibles at $10,000 plus for deductible out of pocket. So you can definitely see how the shift in the last, 10, 15 years has totally gone from very minimal out of pocket for a patient. Well, and even back then, it's still a lot of money, but to now having just always huge amounts of out of pocket. And that's happening for our underinsured patients. So now our population is more underinsured patients that are needing the help because of the high insurance costs and the high out of pocket costs.
Do you see any socioeconomic differences in underinsured patients, or are these issues across the board for everyone?
These issues can be across the board for everyone. We see business owners who just are struggling. If they're a small business owner, they still have the struggles with these out-of-pocket costs and the financial toxicity because of having cancer.
What do you think is the role of the cancer program in mitigating financial toxicity for their patients? Is it secondary and separate to cancer treatment, do you think, or is it an essential part of treatment? Talk about that.
I believe having the cancer center help patients through the financial toxicity. It's essentially, to me, another side effect of a treatment. So along with all of the other side effects they have, not only medical side effects, but the anxiety, and there's also the financial side effect. And patients need help. I think it's our role in the cancer centers to have somebody to help patients navigate through the system. And that should happen right from the time when they walk in the door to help them understand their benefits and what their out-of-pocket costs are, and then help them all the way through their journey when they're in the cancer center. So that way they always have somebody side by side helping them to understand and know what's going on, but also there to back them and help them.
Well, when they do walk through the door and they're newly diagnosed, can you walk us through their financial track and your distress screening from the initial screening education to survivorship?
Sure. So when our patients walk in the door, already we have prepared what we call our benefit sheet. So we know what the patient's out-of-pocket deductibles and what all their benefits are. And then we also check to see, as of current day, what have they met so far, so we know what they can expect to pay. We feel it's important to be able to meet with the patient, educate them. To me, it helps put a patient at ease as well to know, okay, I know that I still am going to be responsible for X number of dollars going forward this year. So we meet with them when they first come as a new patient. We also talk with them when a treatment is determined to decide, do we have foundation help, or is there copay assistance from a pharmaceutical company, or what other avenues of assistance do we maybe need to look at if the patient needs help? If they decide right now, I just don't think I need help, I think I'll be okay for a while, we still go and check back with them in a month to say, okay, now you've had a month, and you're kind of more established, you can see what's happening, do you want to talk more, or are you still comfortable? And we'll do check-ins like that with the patients as we go through their journey, and that is continuous as long as they're being treated through to the time till they get to survivorship. We provide them with business cards, so that way if they are ever in doubt when they're at home and not sure and they have a question, they can call and get directly to a financial counselor or financial navigator. We also have provided a lot of education for our teams within the clinic. So every department in our clinic knows if a patient says anything about financials, about their financials, being concerned about making payments, concerned about medications, any concerns with insurance, it's an automatic phone call to the financial counselors to say, you know what, we have a patient here who has concerns. Can you come talk to them? So that we were able to talk face-to-face with the patient and help them work through that as well. And we found that has been very beneficial to helping ease the patient's mind.
What are the signs that you look for of financial health illiteracy that all members of the team look for? Is there anything that tends to stand out? If it doesn't show up in your distress screening, what are they looking for throughout the course of treatment?
So we're definitely going to look for, when we talk with patients, is there confusion or just lack of understanding? We supply them with not only the verbal information, but we give them a handout as well that explains everything. And we've made sure, we worked hard to make sure that our paperwork is supplied at a reading level that's able to fit most people. I think that's beneficial, and I think that's a huge opportunity we have maybe in other areas of the clinic, and a lot of clinics have opportunity. It's just to help understand that patients don't walk in the door understanding our world and how we talk. I think that as we continue to work with patients with financial health literacy, we are getting better at it. So we're finding ways to change it. If we have someone who's working one-on-one with the patient and they just see that there's still confusion, they don't quite seem to understand what we're talking about, we've actually pulled somebody else into the conversation. So we'll pull a different financial navigator in to have that discussion, because sometimes it's just one person's way of talking or explaining something that doesn't quite work. So we just bring another person in and say, okay, let's sit down and let's work through this a different way and see if we can get to the best understanding. And we found that to be very successful and helpful for the patient.
How often do you have a patient that doesn't understand their health coverage and they struggle with terms like coinsurance or copay or deductible?
Well, I actually asked my team, how many patients do we guess are we having to do extra explanations for? And the consensus was at least half of our patients have a difficulty understanding, if not more. So it's very high. But, I mean, our insurance world is a very confusing world, and everybody's plans are so different.
It's such a private, delicate area, right? The finances of each patient. How do you approach that with a patient with compassion?
Right. So I know initially when we walk in by a patient and explain that we're a financial counselor, the patients automatically assume that we're there to take money from them. So it takes a little bit of talking. And what we do is we approach it as we want to let you know we're here to work with you and work with your insurance company and to help you with your financial side for your insurance and your out-of-pocket costs. So that way you don't have to worry about any of that kind of stuff. We'll take care of it all for you so you can take care of yourself. And I think once a patient helps us see that, it really helps them opening up. And then they're more willing to share. So we'll have patients that are like real hesitant, scared to give financial documentation at first. But ultimately, when they see that we're talking about bringing in assistance to help get rid of those high out-of-pocket costs, they really start opening up and working with us. And we give them time. If a patient isn't comfortable right now, or if they have a family member that they want to talk to first, we're like, okay, if you want to bring your family member in or have your family member call or a friend call, we can help explain what we're doing as well to help put the patient and the family at ease.
I can imagine how, going back to what you had said before, I can imagine that it is really intimidating for a patient to walk in. They think they're walking into, the bill collector.
Right.
Is there any special communication that you do about making them comfortable? These are people here to help you. They're financial counselors. They're not trying to take money from you. They're trying to actually make this easier for you. Is there special signage on the doors, for instance, or is there just different ways that you communicate that?
There isn't any signage. We just approach it with kindness and caring and just that we're here to help them. And we keep reiterating that we're here to help you. We want to make it as easy as we can for you, especially from the financial and insurance side, because we really want the patient to be able to focus on taking care of themselves. And we really keep reiterating that and letting them know, please let us take care of the insurance side for you. We know this is messy. We know insurances aren't easy, but we know some of the tips and tricks from working in this area for so long that we can help make it easier for the patient.
What would you say to your colleagues in other programs who don't have a dedicated financial navigator for oncology? What's the best advice you could give that they could bring to the C-suite to make the case that, these are special circumstances and these folks really need this help?
So this actually just happened to me probably in the last 6 months, where I was at a meeting and somebody came to me and said, Lori, we don't have a financial navigator yet, but we're hoping to get one on board. And after they picked my jaw up from the floor, because my jaw dropped open, and just like, I'm really glad that you guys are getting there. And it's awesome. I said, it scares me for your patients that you haven't been able to have that yet. But I talked to them about the return on the investment. So if you invest in your patients, you're going to be reducing that patient's anxiety. You're going to be reducing their stress from worrying about the financial side of things. You help them by making it easier for them to be able to afford their food and being able to afford their other doctor bills or whatever else they may need. You're helping the clinic and the business by getting money in the door if it's for IV medications, because that could be a total loss. You're reducing the amount of work on the backside if a patient can't pay. So if on the revenue cycle side, if you have a patient that gets sent to collections and you have to work a collections account or keep calling a patient, you're saving that time by helping patients up front. And the amount of dollars that can be brought into the system to help by even having just one financial navigator, you will get more money back to the system than what you will ever pay out in a wage for somebody in this role. So it's a win-win for patients and clinics all over.
I bet that's surprising to some people in some programs.
Yeah, I can share one story. It was in my early years starting the program. I had learned on a Friday that a patient, an elderly gentleman, was going to be starting treatment on Monday, and he actually had Medicare and a supplement. So I knew that he wasn't going to have a large out-of-pocket cost. You know, with Medicare and a supplement, you have a smaller out-of-pocket cost, if, anything at all. So I was really excited to talk to him on Monday morning and let him know this. So on Monday when I got in and he came in for his treatment, I went back to the treatment area and went in his room. And I said, I just wanted to follow up with you and let you know you have no out-of-pocket cost. Your insurance is going to cover everything. And the gentleman, and keep in mind, this was an elderly gentleman who I actually took as kind of like a grandpa figure. He said, listen here, young lady, you need to sit down. And I was like, oh. He said, do you have any idea what I went through this weekend, being worried about this and trying to decide between getting chemo and not getting chemo and what this meant for my family? He said, do you know how much better this would have been if you could have called me on Friday and told me this and what it would have meant to me? And I was like, oh, wow. And back then I didn't know. I was starting the program. I was totally finding things on my own, trying to figure things out. So I had no idea the impact this was going to have on patients. But that one patient story is what made me move forward and not stop and turn around with this program. There's nothing we're not going to try to do to get help for these patients, because I know what he was going through back then, and I believe every patient is going through the same thing. So I want to help them so that way they don't have to go through that.
And you didn't have an appointment with him, right? You just decided to check in with him on your own.
Yep. I just checked in with them. I didn't have an established program at that point. It was just I was trying to figure out what the patients were going to need the most, what was going to work best for the clinic. So I just decided to go and talk to him. And that's kind of the turning moment with our program. And I'm like, wow, this is going to be bigger than I ever thought it was going to be.
Everyone on the multidisciplinary cancer care team has a role to play in financial advocacy for their patients. ACCC recently launched additional modules, including one on financial health literacy, to its Financial Advocacy Bootcamp. Visit the Financial Advocacy Network for tips, resources, and training on how to integrate financial health into the cancer care continuum. There's a link to that in the show notes. Thank you for listening and supporting Cancer Buzz. If you like what you've been hearing, please leave us a review and share this episode with a colleague. That helps us to continue to provide you with the latest in oncology news, practices, and insights. It's easy. Subscribe, share, and review. Next time on Cancer Buzz, we dive into mental health for patients with cancer and how the nuances and supportive services might be different for patients receiving immunotherapy treatment for cancer. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.